during the sectoral analysis, the first step is to know what is the scope in terms of population groups and areas of the analysis, for example, admin 3 or admin 2 level. Then the second step is to collect and update the baseline indicators. I will share with you our list of indicators. You should calculate the number of affected population, affected individuals, and according to this number, calculate the PIN and the severity based on indicators about health resources, for example, the number of health facilities, the number of inpatient beds, and the distance to health facilities, for example, health status indicators, the number of cases of epidemic-prone diseases, or the number of deaths, or the maternal mortality rate, and so on. We have a large number of health status indicators and some contextual factors, for example, violence, overcrowding, access to water, malnutrition, and so on. The next step is to review these figures with a panel of experts. And the cluster should have, for example, some partners that have expertise in the field or who are expert in different subjects. For example, UNFPA should agree on the results about sexual and reproductive health or maternal health. And after this process, you should adjust the initial figures, the population, the affected population, the PIN and the severity. According to in the GIF 2.0, the affected population is the population whose lives have been impacted as a direct result of the crisis. But in protracted crises like Yemen and other countries that have armed conflict since 10 years ago or 5 years ago, this definition of the affected population may be adjusted to include populations distant to the initial impact of the crisis or to include additional population groups. For this reason, the affected population and the PIN should be based on an analysis about the context. And for example, it depends on the data available that you have. For example, your affected population could be the total population in districts affected by the crisis, or in protracted crisis, you could take only some population groups, for example, IDPs or refugees. As I mentioned, it depends on the context. And these are the options to calculate the affected population. In protracted crisis, we recommend to take the population not covered by the health system, but in sudden crisis, our affected population could be the total population or some population groups. And then the next step is to calculate the coverage or the capacity of the health system. For this purpose, we take the Tanahashi model to calculate the availability coverage, taking the number of health facilities per 10,000 people. And according to some standards, we can calculate the number of people that is not covered by the health system. And population that is not covered could be the affected population, and a percentage of these people could be the PIN. Regarding the indicators for health resources, we usually have inpatient beds, barriers to healthcare services, PIN 500,000 people, and so on. And the formula is to consider the total population, then calculate the number of health facilities per 10,000 people. This gives us a number of the people covered by the health system, and this formula provides of a number of the affected population. Regarding health status, we have under 5 mortality rate, case fatality ratios, incidence rates of of many different diseases. And regarding contextual factors, the IPC level, displacement status, and some additional ones. We have a calculator template, and this calculator template is helpful to calculate those figures. Here, I am showing the data sources for every indicator. Our PIN calculator template takes some indicators about health resources. For example, if you put there the number of health facilities, the calculator provides you the number of affected population and so on for many different indicators. And in the last sheet, you would have numbers like the maximum number of affected population regarding the health system coverage capacity, the affected population according to health status indicators, and the affected population according to contextual factors. And for calculating the PIN, you would need expert judgment. For example, in Central America, they agreed to consider 85% of the affected population as the PIN. This percent was agreed regarding some indicators of the context. For half of the population have a disease every year. 7% of the population are children. Some of them are not vaccinated. And according to those indicators, they agreed to take 85% of the affected population as the PIN. On the other hand, in Colombia, they used some indicators to select municipalities directly affected by armed conflict or natural disasters, take the number of uncovered people as as the PIN, and for the others, they only consider health status indicators, for example, the number of dengue cases or cases of measles. It depends on the context and your expert judgment. And then after having your preliminary PIN, the next step is that OCHA will compare the PIN of all clusters, and GIF 2.0 provides a flagging system, and this system highlights those districts or those areas where inconsistencies may occur. For example, if the PIN is higher than 90% of the population, this district would be flagged, or if the difference between the first highest PIN and the third highest PIN is greater than 100% or 50%. It depends on the thresholds you agreed. And after this workshop and after this review, all clusters should revise their findings, search additional pieces of information or additional evidence to support the analysis. And this is the process for the PIN. As you see, it's not very complex, and the calculator template facilitates all process. And regarding the severity, provides a clear definition for every level. And we have a list of indicators with thresholds for estimating the right severity phase according to this indicator. And then the next step is to calculate the severity per every dimension. We would have, for example, a severity related to health resources, another severity related to health status and contextual factors, and the weighted average would be the health severity. And if you have critical indicators, for example, IPC level or additional indicators related to violence or systematic human rights violations, this critical indicator would be taken. For this reason, we would take, for example, the highest severity between our weighted severity and the severity according to this critical indicator. And then you would have a preliminary severity that you should agreed with cluster partners. Then OCHA will compare different clusters severity, estimate a preliminary severity, and compare the results and highlight those areas where there are some inconsistencies, and you should be engaged to the discussions to agree on the final results and so on. And this is more or less the general process, but most of these sectoral analysis is automated in this calculator template. For example, you have here a list of indicators. You can add those indicators here in the input sheet. Then, according to the threshold, some standards, this template calculate the number of affected population and of severity level. And finally, you would have, for example, a sheet like this, the number of population, affected population, and the PIN, as I mentioned before, is based on expert judgment. For example, you could take 85% of the affected population or a different percentage. For example, in Burkina Faso, they take 50% of the affected population, but 90% of the IDPs as the PIN. And yeah, this is more or less the whole process. So if you are having challenges or problems with OCHA or other clusters, we are here to support you. And if you have doubts about the methodology, the indicators, we are here to support you.